This is a screencast provided by Charlotte Pedley for paediatrics for Sheffield Hallam University. So the purpose of this screencast is to look at paediatrics as a whole and start to think about them from multifaceted approaches, thinking about who we would need to get involved from a physiotherapeutic point of view in order to create a holistic treatment of a child, and also what else we may need to be looking out for from a safeguarding perspective in order to ensure that we're treating the children and the family situation in an appropriate manner. So the aim of this session is to look beyond the physiotherapeutic needs of a child and consider the family as a whole, and also to discuss the impact of perceived norms within society. It's also worth thinking that sometimes when we discuss safeguarding or paediatric patients or some of the issues that may occur with paediatrics, it may be sensitive to yourself or to your peers, and it's always worth noting at this point that student support is available through Hallam Help should you feel that you need it. So what constitutes a child? So just have a pause at this point and have a think about what would be your definition of a child. What do you think constitutes a child's rights? And just make a quick note of what you think a child may look like. Now, most people suspect that a child is anybody under the age of 18, and the biggest mistake I think that is made is trying to treat children like small adults. In terms of treating children, it's important to be aware that they don't present like small adults. They have very different processes in which they're going through in terms of growth. They have a whole plethora of additional needs in terms of care. They have potentially complex social backgrounds, thinking about who else is within that family home, parents, carers, siblings, thinking about their integration into school and future careers. There's all sorts of hormonal changes going on within teenagers, so they can make them quite tricky to deal with and to be able to engage with. And thinking about how, when you're setting goals for patients, how are you going to get children on board with these goals? So when you can instigate reasoning for teenagers, sometimes this is easier said than done, being able to instigate a reasoning profile with a teenager. As long as they can see the outcome of it, then you can get them on board to be able to do certain aspects of a rehabilitation program. When you have children that are of the age where they tend to do what their parents tell them to do, so between the ages of around about 5 and 12-ish, you tend to be able to get parental input into these children so that you can achieve shared goals. But then thinking about those that are under 5 who don't necessarily listen to their parents, who potentially don't want to sit still for the session, or don't want to stand or jump or stand on one leg or breathe into a tube for you. How are you going to engage that population and make the therapy fun so that you can get your therapeutic goal and achieve that therapeutic goal, but also that the child doesn't become distressed, doesn't become uncomfortable, and doesn't become bored? And then how are you going to get the family on board to be able to continue that physiotherapeutic input at home once they're discharged or once they go home as an outpatient? So there's lots of facets involved with treating children because they go from such a vast range, so 0 to 18, and thinking about and having a toolbox whereby you can draw on lots of different experiences and lots of different tools in order to create a package of care for these children is key to be able to have success with treating this age group. So 1 in 20 children have a disability, and up to 6,000 people in the UK have restricted growth. Nearly 1 million people are believed to have a learning disability in England alone, and 10% of children aged 15 or younger have a mental disorder. Now this number is on the rise at the minute, as on the rise exponentially throughout COVID, there's been a big increase in mental disorder and those reaching out for mental health help over the COVID period. So thinking about the mental health side of your physiotherapeutic intervention and thinking about the biopsychosocial model when you're treating children is really important. 6% of children in the UK have a disability, and they're most likely to come from low-income households. And you tend to find that the lower-income households come from within inner-city areas. So some of the most deprived areas in the UK are from inner-city London, Manchester, Sheffield, and the North East. So also being able to think about the area in which you're working and the types of demographic of patient that you're dealing with on your caseload. There's around about 1,800 babies in the UK are born each year with cerebral palsy. So just some points to consider here. So at what age does a child become an adult in the UK? Just have a think about that for a second. What number would you put on that? The answer is 18. So a child becomes an adult at the age of 18 within the UK. So technically by law, anybody under the age of 18 would be classed as a child and would be treated as such in a court of law and within healthcare. So what age can a child give consent legally in the UK? Have a think for a second here and think about what you think the age range would be. The answer legally is 16. So a child can agree to their healthcare or disagree to their healthcare from the age of 16. Now there is some grey area in relation to this, and this is called Gillick competency. I will go on to discuss Gillick competency briefly as we go forward, but it's always worth being aware of the Gillick competency framework. So please do familiarise yourself with this. And just as a note for the bottom one, what is the age of criminal responsibility of a child in the UK? So what is the age that a child can be tried in a court of law for being criminally responsible? Have a think about what you think the age is here. The answer is 10. So a child can be tried in a court of law for a crime that they've committed from the age of 10 in the UK. So Gillick competency, like I mentioned previously, so a child under the age of 16 can consent to their own treatment if they're believed to have enough intelligence, competence, and to fully understand what what is involved in their treatment. So this needs to be done carefully, and this needs to be done with the child's best interests in mind. To deem somebody Gillick competent, you need to make sure that you have discussed with the patient themselves what their needs and wishes are and what they perceive their needs and wishes and goals to be. And do you think as a healthcare professional that these goals are appropriate for the patient? And do we think that the goals are going to cause harm to the patient or harm to the family? It's very rare that a child will go against the wishes of their family in relation to healthcare, and these can be really tricky scenarios to try and manage. But it's always making sure that you understand the reasons behind a child's decision to make reasons, sorry, to make these decisions, and just being respectful of the fact that they do have the choice in relation to healthcare. And how can you best support them in making those decisions going forwards? And it may well be that you need to speak to other members of the MDT to be able to help you with that. So that might be paediatricians, consultants potentially that are involved in the patient's care, sometimes psychology, and sometimes discussing some of the issues with the parents. There would be scenarios where you wouldn't discuss that with the parents. So if the child was asking that not to be discussed with the parents, then that would be something that you would need to discuss with safeguarding. And just being aware that sometimes in some families, parents don't always have the best interests of their child at heart. So it's always worth having that in the back of their mind. What is the underlying driving force for this child's decisions? Is this child at risk? Is there anything that I need to be more aware of? And try to really put yourself in that child's shoes to be able to understand where they're coming from. So working with children and families. So when you're working with children and families, there's several different aspects that you can utilise. So there's familial, educational, friendship, safeguarding, social, and health side of it. So I'll go on to discuss these in slightly more detail. So from a family point of view, um, have a think about that child's family setup. There are so many different aspects of family setups to be aware of. Families don't come in one format. They come in multiple different ways, shapes. There's different members of that family who makes up that family unit. Um, so when you're assessing a child, um, thinking about asking those questions within your subjective assessment to unpick and uncover who is there at home with this child, who's there as the support network, what is the family dynamic, if it isn't a, a family whereby everybody lives under the same roof, how much time are they spending at other people's houses, um, is that child supported within their family? Can you utilise the family support to be able to feed into your healthcare programme? So, can you utilise different members of the family, perhaps siblings, parents, grandparents, step parents, um, to be able to support you with the physiotherapeutic goals? What's the home environment like? Is it suitable for the patient? So this can come into play when you're thinking about planning discharges for patients after illness or injury. Um, and you might want to think about doing a home visit, so actually physically going and visiting that patient's home environment so that you can get a better idea of how you could um, get this patient home, or how you could support the patient. So things like um, young children, so toddlers who perhaps aren't meeting their milestones. Maybe they don't have that. Maybe they come from a background where there's financial difficulty. Therefore, the family can't afford educational toys, or they can't afford interactive toys for that child. And therefore, it may well be that there's not enough stimulation at home for that child to then meet their milestones. So by doing a home visit, you could then um, look at different charities that could get involved, look at speaking to social workers and support workers who might be able to support that family into play groups or into other community groups to support that child in being able to achieve their milestones and achieve their potential. Are there any safeguarding concerns? So, um, within the family itself, is there any concerns for yourself about the family's ability to be able to provide for that child to their best ability and meet all the needs and the basic needs of that child? Is there any safeguarding concerns after you've done a home visit? Is the environment safe? Um, is it safe for the children within that home? Is it safe for the adults within that home? So thinking about situations where there may be evidence of domestic violence, or there may be known domestic violence because the child may be on a child in need plan or a child protection plan. And these plans are in place to support families and to support children in developing and meeting their potential ultimately. And these are plans that go across social workers and healthcare workers to be able to provide a holistic approach to a child's future needs. And it's always making sure that that child is safe, that the child is safe, well, and needs are met. So, how could you utilise familial support in providing healthcare for that patient? I suppose another branch to that is the educational side. So, children over the age of 4 or 5, depending on how old they are as of that September of their school year, and sometimes for children 3 and 4, they're entering into environments whereby they're in full-time nursery, or they have nursery placements, or they're in primary school, and then children over the age of 11 are in high school, all the way up to 18. Um, and after an illness or an injury, how are we going to look at reintegrating that child back into their educational system? So sometimes this can be easier said than done. So a child may not be in a particularly adapted school. It may be an old community school or a church school. that's been in situ for many years. And actually, the access to that school is very difficult. Or there's in high schools sometimes these can be vast um, buildings by which there's lots of stairs. Access points are difficult. You're moving around the school all the time, different classrooms in different aspects of the school. So thinking about the logistics of how you would reintegrate somebody back into a school environment can sometimes be really tricky. There can be very busy environments whereby there's lots of pupils around at the same time. So think about back to high school when the bell went at the end of the day. There's large crushes of students, around at all times. Um, this can lead to injury. It can lead to feelings of anxiety sometimes with some of the patients that you may come across or some of the children you may come across. And also thinking about access to toileting. So for the younger pupils, if they've had a recent injury or illness, sometimes you may discharge a patient home from hospital for parents to care for at home. But then when they go back into an educational environment, they may not have that one-to-one support. And teachers don't necessarily do toileting of children, especially as they're getting towards year 1, 2, 3 and onwards. Um, so getting them back into school if they've regressed on their toileting habits can be really quite tricky. So what support networks can we put in place for that? And again, it might be worth thinking about school visits. So to assess the suitability of the school visit, what changes can be put into place? Do we need to look at different seating? Do we need to look at a different timetable perhaps for that patient or that student, so that they're able to access facilities at the right time and not fall behind in their education, um, because that can cause further issues in terms of them not being able to plan for a future or reach their aspirations or goals. And when we're treating a patient, feeding in the education side of things, it's really important to understand where a child sees themselves as an adult. What is their aspiration for their education? What do they want to do in terms of a vocation? Thinking about 16, 17, 18-year-olds, traditionally it would have been an A-level pathway, but what do they suit better to the BTEC pathways or the apprenticeship pathways? And what do we know about that to be able to facilitate them being able to do that? Part of being a paediatric physio is being able to enable children to be able to reach their potential, um, even if they have potential aspects of reduced ability, disability, mental health problems, learning difficulties, and being able to facilitate that in the right way. And working together as an MDT, so working with occupational therapy, working with schools, and working with uh, social workers, you can put together packages of care and educational healthcare plans. That's the EHC plan that's listed on there, that can put together recommendations for that child to best support them in that school environment. And for some of the more profoundly disabled children that might sit within special schools, they may have educational healthcare plans that span across their education through to toileting, seating, physiotherapy involvement at home and in school, respite care that they potentially may have to give some respite for parents. So these plans are really important for the progression of some people through the education system. And I guess linking really closely to education is friendship groups. So school friends form really significant parts of the growth of students and pupils as they get older. And these friendship groups can be quite fickle sometimes, especially in the primary school years, and sometimes within to high school as well. There can be aspect of bullying. Um, and I think if you cast your mind back to your school days, I think you can probably most people can probably pull out aspects of their school days whereby they can remember fallings out over trivial things or loss of contact with friends for no apparent reason. Um, so these can be really tricky times, and these can feel like quite large obstacles to pupils, especially at that age, because that's the only world they know sometimes. So thinking about if somebody has had an injury or an illness, what's the loss of contact with their friends going to be like, and what impact is that going to have on them? Um, One of the major factors and driving factors at the minute in this day and age, and we go on about it a lot, is social media. So there can be the harmful contact that comes through social media. So messages that are sent that can sometimes be iterated as bullying, or um, sharing of images that are inappropriate, utilising friendship groups whereby people have unfriended people for no reason, and um, not inviting them to certain groups and platforms, commenting on videos in negative ways, or commenting on image in negative ways. So I guess social media does get a bit of a bad press from that perspective. However, if we look at social media as an instigator and a tool, sometimes it's really useful to be able to maintain contact with school friends. So because children and young adults tend to be much more connected to the outside world, sometimes when they have got an illness or an injury, utilising social media for them to be able to engage with their peers and engage with their friends actually works really well. So sometimes that's a really good tool to be able to use with that child, to be able to get their friends into the hospital to visit them, for them to stay in contact, for them to be able to do things like blogging or vlogging about their journey if they're going in for a planned operation sometimes, or even sometimes for if they've had a traumatic injury. Sometimes their friends really want to see what's going on with them and what's happening with them. And this can be a really good tool in terms of psychology for patients to be able to process what's happening to them, and to be able to discuss what's happening to them and open up a little bit sometimes. So it's a really useful tool. It has to be done carefully with the parents' consent at certain times, if they depending on the patient's age. So think back to Gillett competency. So one thing we should always be aware of when we're treating children and adults alike, but children um, have more predisposition sometimes to safeguarding issues, and we should be quite alert in relation to safeguarding issues for children. And we have a responsibility to the child and their families to make sure that we're reporting and dealing with any suspected safeguarding issues appropriately and swiftly. Um, so thinking about types of abuse, so psychological abuse, physical, sexual, financial abuse, modern slavery, discriminatory abuse, neglect, domestic violence, self-neglect and harm, or self-harm, sorry, and organisational abuse. And at this point here, it would be worth just writing a couple of sentences about each aspect of the abuse that I've listed there. There's 10 different types, just so you have an awareness of the different types of abuse that can occur, um, because you will need to have an insight into these to be able to produce and to be able to protect children and their families appropriately. So you do have a responsibility to report or escalate all suspected cases of abuse to a senior or to a safeguarding team. So as a student, we would expect that you would be discussing all suspicions of abuse with your senior at the time of the incident. So being able to pull your senior to one side, or to be able to discuss that with a senior member of staff as soon as is reasonably possible after the incident. It should definitely be on the same day. It should definitely never be left. If a child's in immediate danger, this would be escalated to the police. Again, you would need to speak to your senior in relation to this, um, and they can escalate that and discuss that um, with yourself. If you did think that there was a risk of immediate danger to that child, then you would need to be pulling your senior to one side before that child left the building. So you would need to be just making an excuse or asking to speak to your senior to one side, just so you could discuss your concerns, and then that can be raised in a timely fashion. So socially, children should be exposed to multiple social opportunities. So extracurricular activities that they may be involved in, whether that's sport, whether or not that's specific hobbies, music, dance, theatre, arts, um, and also thinking about if they have had an illness or injury, how can we facilitate their return to play? Most of the time, this is a really useful tool to be able to engage children or young adults back into doing their therapy, purely because what you would do is you would say, right, well, I'm going to look at return to football, for example. and you would then make your rehab program football focused. The same as if you were getting somebody potentially who's had a radial break, who maybe plays an instrument that needs supination and pronation to be able to do that. You would then integrate that into your rehab program so that you're looking at improving that child's ability to be able to return to doing what they love doing. It's always worth thinking about the local play groups that are around the locality in which you're working. And there's multiple different play groups up and down the country. There's lots of baby sensory classes, baby massage classes, classes that potentially occur in your local village hall. These are always worth signposting parents to, so that they've got ideas, because sometimes after having children, it can be quite a lonely experience, especially if it's their, their first child, and they may not be aware of any of the groups that are available. So thinking about how you can support them in being able to find support networks for themselves. And also, again, looking at social media as an aspect to be able to improve interactions between your patients and their peers, if they're already using that platform to be able to communicate with their friends. From a health perspective, thinking about how we can feed into the MDT and who else we could involve in a child's development. So thinking about diet, exercise, their happiness, their access to healthcare and dentistry. So if you do notice that there are issues with how a patient looks or how a child is presenting themselves and they look unkempt or neglected, or their teeth don't look like they're being kept up to, then thinking about how we can inform and educate patients' families about the access to healthcare and access to dentistry or dietitians that would be available to them through the NHS. And do we need to refer through to the members of the MDT ourselves, such as dietitians that may be present within the hospital environment? So this is just a short slide about family-centred practice. So thinking about the 5Fs, so what function are you trying to restore for that patient? Do you need to get family involved in that patient's rehabilitation journey? Thinking about the patient's fitness in terms of health, making that rehabilitation program fun, and does it feed into the patient's future? So does it feed into the patient's future plans? Can you think about their aspirations and their goals, so return to sport or return to a vocation, or future vocational aspirations that you would then target your exercise program or your rehabilitation program towards? So for the next part of this screencast, this is mostly going to be delivered by yourselves, but I will talk through the scenarios individually. And there's just 3 case scenarios that I've outlined that you can just make some notes on and have a think about. So think about the following elements. So the psychosocial factors. Who out of the MDT might you want to get involved for each of these scenarios? What's the role of the physiotherapist within these scenarios? What goals might you be setting for the patient? Think about the family-centred practice. So think about the 5Fs and how you would integrate these. And where does the role of physiotherapy end? Think about what barriers there might be to achieving these rehabilitation goals. So social norms, friendship groups, education, and integration. So scenario 1 is an 8-year-old boy with Duchenne muscular dystrophy has started to have reduced mobility and is being assessed for a wheelchair. He's got a 12-year-old brother who also has DMD, who is now dependent on BiPAP, and has recently been very unwell due to a chest infection. He's been referred to physio to provide him with a new exercise program to maintain lower limb strength and improve gait. So just pause the presentation here, spend around about 5 minutes thinking about what are the main aspects of this scenario that you would want to pull out, who you could get involved from a MDT perspective, and what's your goals here with this patient. So for scenario 2, you've got a 12-month-old baby who's been referred to physiotherapy for delayed developmental milestones. The child cannot sit unsupported. The mum has 6 other children aged 9, 8, 7, 5, 3 and 2. She's also a single mum. You did do a home visit for this patient, but the house is very bare and there's minimal toys for stimulation. How could you support this child and family? Again, so pause this presentation here and just spend around about 5 minutes putting your thoughts down on paper and have a think about how what support might be available for this family, and what would be your barriers to intervening in this family, and who else might you want to get involved from an MDT perspective. And then scenario 3, so 14-year-old girl who presents in MSK outpatients with recurrent shoulder pain, swims competitively for England and is due to try out for the Olympic trials in 6 weeks' time. You notice on assessment that dad's very pushy and wants you to get his daughter back to training as soon as possible. When you assess her, you find some hypermobility and weakness around the shoulder, and you suspect that it could be shoulder impingement. However, you also notice some linear marks on her forearm of the young girl, and these are consistent with self-harm marks. So how would you support this family and child throughout the rehabilitation process? And who else would you involve in this child's care? Again, just pause the presentation for 5 minutes, make some notes about what you think might be the barriers and the facilitators in order to return this child back to function, and also think about who else you might want to get involved from an MDT perspective. So why does it matter to you? So you don't want to go into peds, so why does it matter? So paediatric patients have a habit of popping up even if you don't want them to. So in sports teams, you tend to have the youth teams or the academy teams. In adult services, it's all the family members to think about. So think about that adult's children or their stepchildren or grandchildren. If you work in private, you can potentially be asked to see patients over the age of 16. So again, you're thinking about that Gillick competence. They can self-refer through to private patients. Learning difficulties in adults. So we have a lot more adults with profound learning difficulties and profound health needs because we are much more advanced in terms of healthcare assessment and healthcare provision. So a lot of conditions that perhaps would have been life limiting, patients are now lasting much longer, so we're making it through into adult years, so they fall under adult services. Safeguarding, so who's looking after the paediatrics and the children while they're adults and inpatient. And the NHS when major trauma incidents occur. So if there is a major trauma incident declared, sometimes the beds will change. So as you will know, the most recent national major trauma incident or major incident, would be the COVID situation where paediatric beds were turned into adult beds and adult beds were turned into paediatric beds and vice versa. And lots of services were devolved and put into specific silos, and it would be expected that you would then be able to manage across those silos. So situations do arise where you would have to deal with paediatric patients or have at least an understanding of paediatric patients. So this is just a slide that talks around who might be involved in terms of a child's journey through an inpatient setting, and members of the MDT that may need to be involved, depending on what type of injury or illness that patient presents with. But it's always worth knowing and always worth being aware that no matter what, the patient sits at the centre of this MDT. And you would need to then coordinate who would need to be involved. So if you're part of that MDT, coordinating those meetings, making sure we're involving the right people within that.